Now we're going to go over some general LVAD emergency guidelines for you in the field. It's a busy slide, so we'll go over this a little bit slowly. So just like you do with every other patient when you walk in the house, you're going to assess their airway, or on the scene, you're going to assess their airway and intervene just like you do with every other patient. Please don't let the VAD slow you down. If the problem is not the VAD, treat the patient, because the VAD is just going to run and be fine. So treat the patient. Don't let that slow your treatment down. You always want to auscultate the heart sounds to determine if the device is functioning normally. So you can listen, you should hear a nice whirling, even sound, a nice hum. And again, it should not sound like a rock tumbler. Rock tumbler means there's probably a clot in there, and it's not good for the patient. Again, hydrate and get them to their implanting center. We're going to assess the device for alarms on the controller. So you're going to look on the patient's waist for the controller. It's always going to be there somewhere. And be careful you don't pull on the drive line, because remember, it's connected to the drive line. And then you're going to get that VAD coordinator on the phone, and you're going to read them the numbers on the controller so they can understand what's going on. And of course, if any alarms are going off, the VAD coordinator can help you address the alarm and understand what's going on with the patient and what they need. Every patient should have an alarm guide in their emergency travel bag, and I'll show you that when we get to the equipment section. You always start a large bore IV. You can't go wrong with a large bore IV on these VAD patients, because if they need fluid quickly, you'll be able to give them that. Assess their vital signs and obtain a map with their Doppler. If there's no Doppler available, use the mean on the non-invasive blood pressure machine. But as I said, our patients should all have Dopplers and cuffs in their home, with the exception of one man that lives alone in the city of Palm Beach. You're going to transport to the closest VAD center for emergencies, and always call the number on the device tag for the implanting center. Every patient should have their center emergency number located on their travel bag. So always look at that, and I'll show you what that looks like in a few minutes. Bring all the patient's equipment with you in the rig. So load up their battery charger, their power module, load up their stuff. And it's really important that the significant other or caregiver stay with the patient during transport if possible, especially if the patient's unconscious. They're trained on the device, and if there are alarms that go off, they can address the alarms, they can silence them for you, they can help you understand what's going on with the patient. We can also be on the phone with you as well. So let's go over blood pressure monitoring a little bit so you understand how we get this map. So due to the continuous flow nature of the HeartMate 2 and the hardware, it's often very difficult to feel a pulse and measure the blood pressure. Okay, so you may even feel a slight pulse, but it's not enough to really actually get a good pressure on the cuff. You might get a cuff pressure, but if you have a Doppler, please do the Doppler, because that's much more accurate. Sometimes we get cuff pressures on patients and they're not even accurate. So hypertension affects flow. So if a patient's in a hypertensive crisis, their flow will actually be decreased. So we need to get that patient out of their hypertensive crisis. So a decrease in pump flow and power will occur. They'll have a drop in cardiac output. They probably don't feel well. Their PI can be increased on the HeartMate 2. And in anticoagulated patients, it may increase the risk of hemorrhagic stroke. So we want to get them out of that hypertensive crisis. All right, so let's review how to do a Doppler pressure. You're going to place the cuff on the patient's arm and add gel to the antecubital area. So you'll place the cuff on the arm and you'll add gel to the antecubital area. You'll auscultate the brachial pulse using the Doppler. So once you find it, go ahead and count the heart rate. Record that down as your heart rate. You'll inflate the cuff to about 120 millimeters of mercury, or until the pulse is no longer audible. Then you'll slowly deflate the cuff while watching the sphygmometer for the return of the audio pulse. The first few beats you hear, if you get good at this, will be loud, and they're actually not the map. It is the change in sound to a whooshing noise. So it'll be bum, bum, whoosh, whoosh, and your whoosh is your map. If you can't distinguish that, take the top number. That will be your blood pressure if you can't get the whooshing. There is a HeartMate 3 patient in the area. It's a very similar pump to a hardware pump. It has a little bit of an artificial pulse. So if you come upon this patient is ours, if you come upon this patient, it may be a little bit more difficult to get that blood pressure, because you can actually hear that artificial pulse every few seconds revving up. So it makes it a little more difficult. Okay, so HeartMate 2 and HVAD QA. So let's go over a few things that I need you to remember about these patients. Can you do external CPR? Yes, please don't use the device that you have in the rigs that's not manual. So manual CPR only if absolutely necessary. Remember that green light on the HeartMate 2 controller. If that light is off and the patient's turning blue and you've changed the system controller, then you can go ahead and do CPR on that patient, because dead is dead. Let's see, there's no hand pump or external device to use, so don't look for anything. If any of you have been around for the first generation VADs, there was an actual hand pump that went with that pulsatile device, but there are no more of those VADs available in the community. They're not used anymore. No patient should have that VAD, so no. There is no hand pump or external device to power that pump. If it's off, it's off. If the device slows down to a low flow state, what alarms will go off? So if a patient's hypovolemic, or they have a thrombus in their VAD, or they have a hypertensive crisis, an alarm indicator will go on with a steady sound or a loud alternating sound depending on which VAD you have, and the sound falls below a specific level. You'll give a bolus of normal saline and transport to the VAD center, and of course you'll always have called the VAD coordinator and you'll be speaking with them on the phone. How can I speed up the rate of the device? It's a fixed speed. You'd have to be at the hospital with us on the monitor to do that. Can the patient be defibrillated while connected to the device? We covered that already. Yes and yes. If the patient can be defibrillated, is there anything to disconnect? No, there's not. Does the patient have a pulse with this device? The patient may have a very weak pulse or lack of a pulse. And then what are acceptable vital sign parameters? Again, that map of 70 to 80, 85 is acceptable, but we usually start treating at that point with a narrow pulse pressure. Can the patient be externally paced? Absolutely, go ahead. Is the pulse oximetry accurate? Probably not. So do not go by the pulse oximetry. If a patient is blue and the pulse ox says 90, that's probably not accurate. Vice versa, if the pulse ox says 70 and the patient's pink and warm and breathing fine, it's probably not accurate. But you can always throw some O2 on them, a couple of liters, just to be on the safe side. Some reminders for HeartMate 2 and HVAD. Again, pulse oximetry and automatic blood pressure cuffs are most likely not accurate. Please look for that Doppler. And the caregivers or spouses of these people are trained to do blood pressure. Have them do a blood pressure for you. They're trained in it and they know how to do it. Patients have that drive line, which is that electric line exiting their abdominal area, which is attached to the computer, the controller that runs the pump. So please be careful when transporting the patient. Don't get that drive line caught in anything, because you could fracture that drive line. You want to be very careful of their abdomen so that you don't disturb the integrity of the skin around that drive line. We hope that it heals so that the skin grows up to the drive line, but if there's trauma to the site, that can cause infection as well, so we don't want that to happen. The pump should not affect the EKG. For those of you that were around for the HeartMate 1, the big pulsatile pump, it made a crazy EKG tracing. Was very hard to read. That's gone, so your EKG should be a normal tracing and you can trust what you're looking at. All ACLS drugs can be given. Again, no hand pump is available, and the batteries last different amounts depending on the device. So again, HVAD batteries are 8 hours and they drain 1 at a time. The gray batteries for HeartMate 2 are 8 to 10 hours and they drain simultaneously. Again, the HeartMate 2 has a backup emergency battery in the controller. The hardware VAD does not. Any emergency mode of transportation is okay and they are permitted to fly. So when you call us on the phone, sometimes we may need you to, if it's the middle of season and 5 o'clock and it's going to take you 2 hours to get there, flying might be faster. So we'll talk with you over the phone to determine the urgency of the patient's transportation based on what's going on with the patient. If they're fully thrombosing their VAD and they're in heart failure, we're probably going to need to fly the patient. Make sure to bring all the patient's equipment with them to the hospital as well. There are a few restrictions that we give our patients. Of course, no excessive jumping or contact sports. There is a woman somewhere in the nation that finished a marathon with a HeartMate 2, so she was probably doing a little jumping, but she did very well. No swimming, of course, because it's an electric device, so we don't want any submersion in water. No exposure to MRIs. Static discharge can be a little bit of a problem, more specifically with the HVAD We tell patients don't take the clothes out of the dryer, stuff like that, for static discharge. And then of course no pregnancy. We tell patients that, but there's been a couple of babies born on the HeartMate 2, which is a little scary. So in closing, remember to auscultate to ensure the pump is operating appropriately. Look for the green light on the HeartMate 2, and then for the HVAD, it will be alarming if it's off. There may be no palpable pulse. Standard measures for blood pressure and pulse oximetry might not be reliable. Look at your patient. The pump is preload dependent and afterload sensitive. What does that mean? We have to have volume coming into the left ventricle, right? We have to have volume to pump, and we also need to control the systemic blood pressure. We can't have too high of a pressure because the flow will go down. So we need to make sure that the patient is adequately balanced and pressurized. Check that the pump is functioning properly, again that green light, and check for alarms and confirm that the driveline is attached to the controller. And then of course call the VAD coordinator at the implanting center ASAP. And here at Delray, if you cannot get a hold of any implanting center in the area where you're servicing a patient, please page us and we'll try to help you save the patient, and we'll notify the center when we can get a hold of them. Thank you very much.